The European Union delegation to Nigeria and ECOWAS essentially is a strong player in the development cooperation arena, and the main interlocutor is the Ministry of Budget and National Planning. And that ministry was selected because it's a ministry that has a handle on what the various ministries are doing by way of planning, programming, and all that. And so it's commonplace to think that if all partners were to go through that ministry, then you will have a coherent and aligned, harmonized programming platform that everyone can engage in. And it reduces fragmentation on the long run. So the EU walks through that ministry, helps to strengthen the capacity of that ministry, and builds its capacity not only to handle European development funds, but also to absorb funding from other potential external sources. Now, when it comes to health financing, the health sector, it's a very interesting one because Nigeria is a federal system, so it has federal, states, and local government, and all these levels have different areas of degrees of autonomy. So it's a pluralistic health system, and so you have to be very careful how you engage. Now, don't forget that Nigeria has an oil-based economy, so in some senses it has some sizable resources. And when you put all the external funds together, it is not as you will have in some other countries where it's quite sizable. So for the European Union to make an impact, it has to be strategic in the deployment of such resources. As the EU, we have decided to work very closely with the government, and like I said before, the Ministry of Budget and National Planning is our main interlocutor, but there are various thematic areas that the responsibles are appropriate ministries. Like for primary health care, you have the National Primary Healthcare Development Agency. And in the past, we used to provide a technical assistance, which was more like a parallel implementing units, and they're efficient, of course. They know the EU procedures and how to deploy funds. The challenge was that when the project ends, that is ended. So what is now operational is that you have you still have some technical assistance, but it's embedded within the government and where government systems. And so where you have existing government mechanisms that are working, they might not be perfect. You do the best to support and strengthen them rather than create parallel mechanisms. And working through that modality, you developed a critical mass of government personnel and counterparts who can continue with the technical assistance, so to speak, even after the project ends. This is not to say that we do not leverage on the technical expertise of bodies like the UN agencies and international NGOs that have the know-how. There's no need reinventing the wheel, but we as much as possible ensure that they work with the government counterparts to be able to leave some skills and ability behind us. Currently, what we do is to have short-term, how will I put it, short-term interventions of 3 years, 4 years, 5 years that has a start and stop that you fund to address specific needs or gaps that you find in the health system. We call them projects. So every project has a lifespan. What we try to do to mitigate the effect of that is that we try as much as possible to use government counterparts and build their capacity while the project lasts. So that is the mitigating measures we put in place. But otherwise, the budget support or putting money on budget is one way that you can actually address overall capacity development of a system. Yeah, we will get there.